Welcome, colleagues. As a fellow intensivist and AI researcher, I am absolutely thrilled to guide you through this explainer today. We're going to be breaking down a really impactful lecture created by Dr. Nithyanand Rao, a brilliant critical care physician. Now, this talk was originally crafted for our critical care consensus meeting, specifically tailored for you, the ICU doctors, who are looking to understand exactly how artificial intelligence is going to reshape our daily practice. We're going to take a deep clinical look at what's real, what's just hype, and what this actually means for us right at the bedside. Okay, let's just dive right in. Before we even get into the tech, we've got to ground ourselves in the clinical reality we're fighting every single day. We all know the absolute frustration of dealing with pan-resistant bugs in our units, right? But the macro scale, it's honestly terrifying. If left unchecked, uncontrolled antimicrobial resistance is on a trajectory to cause 10 million deaths annually by the year 2050. I mean, let that sink in for a second. It's literally projected to surpass cancer as the leading cause of global mortality. While we've made these incredible strides in stabilizing metabolic diseases, the biological expansion of multi-drug resistant pathogens threatens to throw us all the way back into a pre-antibiotic era, an era where our therapeutic options simply don't exist anymore. To tackle this, today we'll systematically explore 5 key areas. First, the global crisis. Then we'll demystify clinical AI. Look at how it's revolutionizing diagnostics, establish our predictive versus generative guardrails, and finally, outline a practical implementation roadmap for your ICUs. So, let's begin with part 1, the global crisis, and specifically the severe diagnostic bottlenecks we're facing. Now, as critical care physicians, we all know our reliance on empirical, broad-spectrum antibiotics isn't born out of carelessness. Not at all. It's driven by severe systemic diagnostic bottlenecks. Just think about your last admission for undifferentiated shock. Sepsis overlaps heavily with non-infectious inflammatory states, doesn't it? And because the mortality risks of delaying treatment are just so incredibly high, we routinely fire off broad-spectrum therapy as a protective measure. We're essentially forced into this corner because traditional blood cultures require 24 to 72 agonizing hours just to isolate and identify the exact causative organism. And let's be real, in the ICU, 72 hours might as well be a lifetime. Furthermore, standard lab tests often suffer from lower limits of detection. That means we naturally hesitate to de-escalate therapy because a negative test just isn't always sensitive enough to definitively rule out a lethal infection. So, how does artificial intelligence actually fit into solving these deeply biological problems? Let's move right into our second section and demystify the core technology. First things first, it is absolutely vital to understand that AI is not magic. In fact, artificial neural networks are essentially mathematical mirrors of the biological cell pathways we all learned about way back in medical school. Think about it. In our biological neural networks, dendrites capture biochemical pulses, the soma integrates that action potential, and synapses regulate transmission via neurochemicals. Well, the mathematical neuron does the exact same thing, just in code. The inputs act as your dendrites, feeding the data in, the processor is the soma, aggregating those inputs, and crucially, the weights act as your synapses, adjusting the strength of the connection to accurately predict target clinical states. It's biology translated into math. And just like when we're testing a new vasoactive drug, these algorithms have to graduate through 3 distinct, highly rigorous phases of validation before they ever touch a patient. First up is the training phase. This is where we feed the model massive data sets of patient records to calibrate those mathematical synapses, the weights we just talked about. Then comes phase 2, the validation phase. This is where we test the algorithm on unseen patient subsets. Now, this is absolutely critical in medicine to prevent what we call overfitting, which is where a model just memorizes the training data but fails completely on new patients. Finally, once it's proven safe and accurate, we reach phase 3, active inference. This is the stage where we embed the validated model directly into your hospital's EHR architecture to start firing off real-time clinical warnings. This rigorous 3-phase validation enables a massive leap forward from how our computers used to operate in the clinic. And that leads us perfectly into our third section, revolutionizing diagnostics. Okay, so the core paradigm shift in clinical computing here is moving away from static rules. For decades, traditional programming relied on a human having to write rigid if-then code. Like if a patient's creatinine clears X threshold, then trigger an alert. But machine learning flips this entire concept on its head. Instead of relying on pre-programmed guidelines, we feed the machine learning process our patient data and our desired clinical outcomes, and the algorithm itself generates the optimal predictive rules. It essentially learns to dynamically forecast emergent bacterial resistance profiles directly from the vast complexity of diverse clinical datasets. It's finding subtle patterns that human eyes simply cannot see. In practice, this predictive intelligence is completely revolutionizing the clinical microbiology lab. I mean, we are literally seeing high-resolution neural networks automate gram stain analysis right now, rapidly classifying bacterial shapes from digital smears. We've got continuous computer vision tracking culture plates, flagging positive growth cycles hours, and sometimes even days earlier than human technicians ever could. On top of that, machine learning algorithms are now processing complex MALDI-TOF mass spectrometry peaks for lightning-fast genus identification. And bioinformatics pipelines, they're processing raw whole genome sequencing to instantly map antimicrobial resistance traits. It's a total game changer.
So, what does this whole lab revolution actually mean for you standing at the bedside? Well, it means we can finally bypass that painfully slow traditional phenotypic testing. By combining these live lab diagnostics with longitudinal patient records, AI engines can calculate incredibly targeted antibiotic regimens. We're talking about precise agent selection, mapped directly to a patient's real-time organ function scores. We're talking adaptive dosing thresholds to optimize pharmacokinetics, and statistical forecasting that literally tells you the optimal therapeutic de-escalation date. Guys, this is the end of the 72-hour blind empirical waiting game.
But as we adopt these incredibly powerful tools, patient safety absolutely demands that we establish strict operational boundaries. Let's look at predictive versus generative guardrails. If you take away just one technical concept from this explainer, please let it be this clear delineation. We must strictly separate Track A from Track B. Track A involves predictive machine learning. These are task-specific pipelines engineered for structured, numerical inputs, like your local antibiograms. They operate on validated mathematical weights with highly verifiable accuracy. Now, Track B involves conversational large language models, or generative AI. Think ChatGPT. These are foundation networks predicting sequential text strings. They are general purpose, and most importantly, they are highly prone to generating plausible-sounding clinical hallucinations.
So, the absolutely crucial point here, our core bedside takeaway, is this. Large language models are not ready as autonomous prescribers. Hallucination and therapeutic toxicity are formally measured failure modes in the current literature. These are not just theoretical concerns. Now, don't get me wrong, LLMs are highly useful as a secondary reference source or maybe for summarizing extensive research notes. But because of their unpredictable nature, they must never, ever act as the standalone decision maker for an individual patient's antibiotic regimen. Instead, it's those task-specific predictive models from Track A that actually keep our patients safe. Let's look at a quick case study of dynamic EHR monitoring to see this in action. Here, the model isn't generating text, it's actively cross-referencing live medication orders. In this specific example, a patient is prescribed Arsenex and Combinex. The AI immediately flags a cumulative overdose, recognizing that the overlapping medications deliver 600 milligrams of isoniazid, which is well above the normal limit, radically increasing hepatotoxicity risks. On top of that, it flags a renal caution for pyrazinamide based on the patient's specific hemodialysis profile. This is what we mean by actionable, verifiable intelligence preventing harm before the drug is ever even administered. All right, let's move to our fifth and final section to see how all of this builds into systematically bringing these validated systems out of the academic sandbox and right into our active wards. Let's look at the implementation roadmap. Dr. Rao outlines a highly strategic four-step timeline for this migration. Step 1 is ensuring robust data infrastructure, meaning your EHR systems have to talk to each other cleanly, no silos. Step 2 requires tightly controlled clinical pilot trials right in your hospital to measure actual improvements in antibiotic days of therapy. Step 3 is workflow integration. We have to embed these AI warnings cleanly into existing order forms and ward rounding logs to minimize alert fatigue and clinical disruption. And Step 4, which is so crucial, is collaborative training. We've got to train our physicians, our pharmacists, and our nurses on exactly how to interpret the model's logic so we build mutual confidence in these systems across the whole team. A completely non-negotiable part of this frontline clinical implementation is mandatory local validation. Every single deployed medical AI algorithm must be rigorously back-tested against your specific hospital's strain resistance rates. You simply cannot import a standard Western literature dataset or some generic patient database and expect it to accurately predict resistance in your specific local ICU. It just doesn't work that way. Your clinical decision support systems have to calculate outputs using your local hospital antibiogram records. And again, keep your LLM interfaces restricted exclusively to clinical education and resident training. Now, when we follow this structured, validated approach, the real-world wins are nothing short of phenomenal. The AI toolkit transforms clinical workflows across the board, from real-time decision support and local surveillance to diagnostic triage and automated audits. The result? Well, we drastically shorten the time to optimal targeted therapy. In fact, multiple peer-reviewed trials demonstrate a 15 to 30% reduction in broad-spectrum antibiotic use right at that critical 48-hour mark. And that, colleagues, is exactly how we actively fight back against those 10 million projected AMR deaths. The era of computational antimicrobial stewardship is officially here. The tools are ready, the efficacy is proven, and frankly, the ethical mandate to act is clear. Which leaves us with one final profound question. As critical care leaders operating at the very epicenter of this global resistance problem, will we step up to lead the AI transformation in stewardship, or will we choose to be left behind by it? The strategic timeline to engage isn't tomorrow, it's right now. Thank you so much for joining me in this explainer today, and I strongly urge you to start championing these targeted pilots in your own ICUs.